want to talk a little bit today about the medical response to sex trafficking victims. I think that as medical providers working with kids who are sexually and physically abused, we are the natural people to be able to do the medical evaluations on kids who are victims of trafficking. Objectives. We need to, at the end, I'm hoping you're able to list 3 challenges to victim identification, recall possible indicators that a patient may be a victim, identify essential elements of obtaining a history from a child, and I'm not talking about a forensic interview, but a medical history. Explain the components of the medical exam, the testing, and the treatment, and then list some of the common referrals that we make. So we've got a lot of ground to cover. Before we start, I just want to emphasize that what we know about child sex trafficking, or any trafficking really, is very limited at this point. There are very few studies. They're mostly qualitative studies with small sample sizes. They tend to combine adults and kids, foreign versus domestic victims. So we don't have really good hardcore science yet. In 10 years, I think the situation will be much different. But what we're going to be talking about is based on relatively limited data. So just keep that in mind. Why should we care about child sex trafficking and human trafficking in general? Well, for one thing, it's a gross human rights violation, but also, as healthcare providers, we are in a good position to have contact with potential victims because in many cases, children or adults will seek medical attention, either for an injury, for example, sustained during a period of violence during their period of exploitation, or a sexually transmitted infection. They may be pregnant. They may be the mother of a baby you're seeing. So there are lots of different ways we can come across victims, and there's good evidence to suggest that victims will seek medical attention. In one study of New York City youth who were essentially homeless and being commercially sexually exploited, over 25% of them had been to have STI testing recently, and a lot of them reported doing it routinely. And there are a number of studies, small studies, but consistently show that there are interactions with the healthcare world. And so it gives us a chance, if we can figure out when we see a victim that this is a potential victim, we can potentially offer services or intervene or be of some help. Well, victims are going to seek care in a variety of settings. We typically see them in the emergency department, sometimes in our child advocacy center, but they also go to urgent care centers, public health clinics, STI clinics, teen clinics, private pediatricians. Some kids who are victimized live at home. They have their own private pediatrician. They go to there. So it can be under a number of different medical settings where you might come across a boy or a girl victim of human trafficking. There are lots of challenges to identifying human trafficking victims, and not the least of which is that most kids do not see themselves as victims. They don't go walking into the urgent care and say, "Hey, I'm a victim. I need to be saved." Many children are victims and do not realize that. They don't see that they're being exploited. They think that their boyfriend, who is the trafficker, is really their boyfriend looking out for them. So they are not going to identify as victims. They're not going to identify as somebody who needs help. They're not going to welcome our help. We're not the white knights sailing in to help them. And for other reasons, they may be reluctant to disclose. For example, in many cases, kids are lured into child sex trafficking because they are promised things, a modeling career or a good job or a romance with an older man who turns out to be the trafficker, but they think he's their boyfriend. Well, at the point where we see the child coming into the emergency department or the clinic, they're still thinking this guy's their boyfriend, so they want to protect him. They don't want to tell about the things that he's done to them. They do not want to get him in trouble. So they may be protecting him because they, quote, love him, or there may have been threats involved. When you go into that emergency department, you tell them you broke your leg because you fell downstairs, and don't say anything about what's been going on, otherwise I'll hurt your family, or I'll hurt you, or I'll take those photographs that I had of you having sex with another man, I'll put them on the internet. So don't say anything. Kids are threatened, and they're not going to say anything. Sometimes kids and adults as well feel a lot of shame and guilt. They feel like they're manipulated by traffickers to feel that they themselves are responsible for their plight. And so they may feel very embarrassed to say something to medical providers. So that may be another reason why they either don't tell us the truth or don't disclose. There is no clinically validated screening tool for medical settings right now. We are working to develop one, and I think a lot of people are working to develop them, but right now we just have to go on a lot of suggestions that various organizations have, human rights organizations, and they're well founded, they're based on risk factors, but there is nothing, you can't just turn to a screen of 5 questions and say, oh, that'll pick it up. We don't have that luxury. But we can consider the kinds of conditions that the child is likely to experience in the life of exploitation and how that might lead the child to seek medical care. For example, there's a lot of violence and abuse. And this can vary from child to child, and every child has a different story to tell. Some will say, oh, in general, there's very little violence. It's only when I did something wrong, then they get beaten up. In other cases, kids are trafficked by what is called a guerrilla pimp, and he uses violence most of the time. So there's a spectrum. But at some point, most kids have had some sort of violence, either from the trafficker or from a buyer. Lots of sexual assault, lots of violence from the buyer on the street, and that's violence against boys and girls. So they may seek help for an injury, for example. A lot of sexual assault. There may be anogenital injury, and they're coming to you. We've had children present to our emergency department as a history of acute sexual assault. That's it, acute sexual assault. And it turns out, once you ask a lot of questions, that it's in the context of child sex trafficking. So it's a much bigger issue than a single episode event. In some cases, many cases in fact, girls are encouraged not to use condoms when they have sex with the buyers. People pay more if they don't have to use a condom. And so many times there's unsafe sex. So you may be treating a child for an STI or pregnancy, for example. A lot of kids are introduced to drugs and alcohol. It's a wonderful way to control somebody. If you can get them hooked on cocaine or hooked on heroin, it's a great way to control them. And the traffickers will often actively do that. In other cases, kids will report using drugs and alcohol just to get through the night, just to get through the stressful part. There's one study of boys in Canada who were using survival sex, and a lot of them said, I just can't do it without being high. I just cannot go out there unless I'm high. So there's a lot of drug use, and we may see kids who are withdrawing or kids who have overdosed, for example. And then in some cases, there's poor working or living conditions. It's not uncommon for kids to be punished by being locked up in a room without any food or water for several days, or live in very crowded conditions. And so there's malnutrition or other infectious diseases that spread among the group of girls, for example. These are the kinds of things that we can expect from kids who have been trafficked. And there's a lot of just brutal physical abuse. The burning with the cigarettes, the choking, beating with hangers and whips, and this and that, throwing kids down the stairs, for example. There may be closed head injury. And so you can see this tremendous variety of potential injuries that we may come across when we see the child. And so it's interesting if a child comes in as an acute sexual assault and we're asking questions and doing our exam, we may come across a lot of this other stuff because that's sort of background violence that she hasn't mentioned, but we may see anyway. So we need to keep that in mind. Many kids have, and adults as well, have chronic pain as an ongoing kind of long-term problem, and that may be partially because of old injuries, partly related to work injuries, or in some cases related to stress. And it's a sort of a PTSD, psychosomatic issue, and they have headaches and backaches and muscle aches and abdominal pain. So that may be something that they come to you for. These things are not uncommon and can be very brutal. And these are just some of the injuries that you often see, the neck injuries from ligatures, a lot of extremity bruising. And again, this is not necessarily at the hands of the trafficker, but also from the hands of the buyers as well. And sometimes there's violence between victims. For example, if 3 girls have to get $1,000 a night as their quota, they may argue over buyers because they have to get their quota. They don't get their quota, they get beaten up. So there may be violence between the 3 of them. Sexual abuse is very common, and this is especially common in the indoctrination period when the child is being prepared to be turned out. So it's that point when the relationship with her boyfriend changes, and suddenly she realizes he's not her boyfriend, he's her pimp, and that he's getting her ready to be turned out to work for him. And so there's often rapes, gang rapes, multiple rapes, acute assaults, as a way of establishing control and breaking the child down so that she does not have the will to resist and does not even think about trying to escape. And so there's a lot of sexual violence in the beginning, and then ongoing sexual violence, again, at the hands of the buyers. And boys especially can get a lot of violence from buyers as well. It's not uncommon for them to report extreme violence, being beaten up and then dumped out in the middle of nowhere outside the city after a buyer is done, or being kidnapped and beaten. And then sex without lubricants can lead to more trauma. A lot of rough, violent assault sex can lead to anogenital trauma as well. Sexually transmitted infections are very common. We see a lot of, I'm not sure what you all see, but we see a lot of chlamydia some gonorrhea, a lot of trick. Haven't seen a lot of syphilis and very little HIV, but we see a lot of chlamydia and gonorrhea. And that can lead to, as you know, pelvic inflammatory disease and infertility, for example. So there are a lot of long-term problems. And a lot of this sexual assault leads to PTSD, post-traumatic stress disorder, as does the physical abuse and the psychological manipulation. So seeing a child who has PTSD is not at all unusual in this circumstance. Sexually transmitted diseases, the infection rate is going to vary somewhat with the region where the child is working and where she comes from. But often, as I mentioned before, they're forced to have sex without a condom, and so it's very high-risk sex. And infectious diseases are very common. In some other cases, it's very interesting. In some other cases, kids will say, oh yeah, I use condoms all the time for buyers, but I don't use it with my boyfriend because I don't want to offend him. So I don't use a condom with my boyfriend, and he's the one who's going to give me HIV or gonorrhea or something. So they may get an STI from their trafficker. And this is just kind of a background statistic. You may be familiar with this, but you have an average sexually active adolescent girl who has a single episode of unprotected sex. She's got a 30% chance of acquiring herpes and 50% chance of acquiring gonorrhea. Now imagine a child who's doing that 25, 30 times a month. That's a real high risk, and it's not unusual for us to see kids with sexually transmitted infections and PID. And here again, adolescent girls have 1% risk of HIV, and we think, oh, HIV, it's not going to, you never see that. Well, it's very high risk here. And because there's so many people, it's unprotected sex, these very high risk people who come to buy sex, and so the child really is at high risk. Adolescents are at increased risk relative to adults. And part of that is because the adolescent cervix is not as well developed, it's not finished maturing, and so it's more vulnerable to HIV infection. It's also thought that some of the increased risk of adolescence is related to the possibility of more violence during sex when they're being exploited, and an inability for young kids to be able to negotiate condom use. I mean, think about it. It's hard for a 13-year-old to force a 250-pound guy to use a condom if he doesn't want to use a condom. And there are certain techniques you can use to try to increase your likelihood that they'll use a condom. For example, bringing that up right before they have sex instead of when they're negotiating the fee. That increases the likelihood that they're going to actually do it, use a condom. But a 13-year-old girl probably has not had that advice given to her, so she doesn't know. So her risk is higher for that reason as well. Pregnancy is very common. In one study of kids in San Francisco, about 16% related being pregnant at some time or other, and many kids will go on to keep the pregnancy and keep the baby. If they're using drugs, if they're being beaten up, if they have a very, very stressful pregnancy, they can have kids with major problems. And so you may be seeing the child of the mother who's being trafficked, for example. And I used to think that unsafe abortions, those back alley abortions, I think, oh, those something that happens overseas. That doesn't happen in America. It does happen in America. And I had, it was very nicely pointed out to me by a survivor who said, oh yeah, I was pregnant and I was taken to some room behind some building. I don't even know where it was. And this guy apparently knew my trafficker because they were talking like they were friends. And I don't know if he was even a doctor. It was pretty bad. I bled a lot afterwards. So we may be seeing kids who have complications of unsafe abortions. And then I think the psychological abuse is something that we as medical providers have to be really conscious of. And I think this may be more damaging than everything else. The extreme manipulation and extreme psychological abuse that goes on just breaks down the child's will to go on and to be an independent thinking person. So they become more and more and more broken down and dependent on the trafficker. There's a lot of guilt and blame and shame built into this, and that's a great way to control the child. And the literature on prisoners of war undergoing torture suggests that two of the major factors that will influence a person's ability to physically withstand the torture, two things: their ability to have some sort of control and their perception of predicting what will happen next. So predictability and control, sense of control, are very important factors to be able to control your stress level. Well, traffickers go out of their way to keep kids off guard. They move them around a lot. They beat them up intermittently and unexpectedly. There is no control and there's no predictability in a child's life when they're being exploited. And so that can add to the risk of the psychological trauma. As I alluded to before, drug use and alcohol use is common. Again, kids who are at risk for trafficking may already be using drugs. If they're already very heavily into drugs and alcohol, they're easy prey for traffickers. On the other hand, if they've never used drugs, the trafficker may encourage them to use it and may even get them hooked within that first week during the indoctrination phase, because they're very easy to control afterwards. If you have somebody who is craving that next heroin fix, they're much more likely to be compliant with a gang rape type of situation with a buyer or having unprotected sex, because they'll do anything for the next fix. In other cases, kids will use the drugs because they feel like they have to just deal with their own stress or deal with their depression. So it's not unusual to have a positive tox screen when you see kids. We see a lot of marijuana is very big, cocaine, and mollies were big for a while. Everybody was talking about molly for a couple of months. Every third kid seemed to come in and said they had mollies. And then this is less common, I think, with kids who are domestically trafficked, but foreign nationals who are exposed to very difficult working conditions. They may be housed in the back of a brothel and there are 9 people in one room and they're not allowed out, and so there's infectious disease going around with them, or other kids as well. It's not just them, but there can be very bad working conditions. And if the child is out on the street and it's very hot or very cold, they're going to have those weather conditions that can be very unsafe as well. This is less likely to happen more now because so much more of the business is transacted not on the street but over the internet, and so it's an out-call, in-call type of business, and there aren't as many kids and women just standing out on the street. But it's still, the living conditions can be extremely bad. And then we have to think about the chronic uncontrolled conditions. Think about how many adolescents you see who have asthma, for example, or eczema. Well, if they're out on the street and they're being trafficked, they don't have their little nebulizer with them, they don't have their medications, and so they may come to you with an acute asthma exacerbation or seizures because they've been off their seizure meds for 2 months. So there may be a lot of untreated medical conditions, not the least of which may be malnutrition and dehydration, especially if they have been locked up and not fed or given fluids. Chronic fatigue is a big complaint of survivors. And this is a long-lasting complaint. In one study of European adolescents and women, they followed the women for several months after they were rescued from the life. And this chronic fatigue was seen in the majority of people, and it stayed. 3 months out, they were still complaining of just this total exhaustion. And so that might be something that we see. So, okay, we talked about all the reasons why a child or an adult might seek medical attention, but how do I know them when I see them? If we don't have a screening tool, what do I use? Well, the victim may be accompanied by different people or may come alone, so that in itself doesn't really help us. We've had kids come in alone. We've had kids come in with other kids who are also being trafficked. They may come in with their parent. It's not unusual for kids to be trafficked, out on the streets, run away, be trafficked for a week or two, then come back and be at home for a while, and then go out again. In some cases of kids who are recruited by gangs, they actually live at home and then go out at night and get trafficked and then go home. So they spend a lot of time out at night. Parents don't really realize what's going on, but they're actually living at home. So they may be brought in by their parent, and they may be brought in by a parent who is also their trafficker. That's not unusual either. They may be brought in by somebody who claims to be their parent or a relative, an aunt, an uncle, but who is actually a trafficker, or what's called the bottom bitch, the highest level female in the group who's had the most experience, is kind of the right-hand person of the trafficker. She's often the manager, and she may bring the child in. So there can be a lot of different circumstances, and it behooves us to keep in mind, we don't know exactly who these people are and whether they are going to keep the child safe. So these are possible indicators. Again, nothing proven. This is not a validated tool. But in some cases, if a child comes in and is accompanied by an adult who is very, very dominating, won't let the child talk. You ask the child a question, he answers. You ask her a question, he answers. He's hovering. She seems to be afraid of him. She's not making eye contact. She's just being very soft and withdrawn. That might be a clue. And it's kind of like that intimate partner violence relationship with a very domineering person. The woman is very quiet. That might be a clue, and that's not a given, but that might be your first clue. If the multiple girls present with one adult, for example, they all have a vaginal discharge, then you should start thinking about it. A child comes in alone and gives false information, for example. If the child can't tell you where they are, where they're staying. Now, remember that a lot of kids are transported from city to city on a route. And so they may not really be knowing where the heck they are. Today it's Atlanta, tomorrow it's New Jersey. So they're not familiar with where they are. They may be in a hotel But if they may not be able to tell you where it is or what hotel it is. And you might say to yourself, well, a lot of kids who are on vacation have problems and end up in an emergency department, and that's very true. But usually if you're on vacation with your child basically knows what city they're in, and they can say, well, I'm at the Best Western, or I'm at the Holiday Inn. You know, they sort of have that. But if the child is pretty clueless, doesn't have really any idea, that could be another possible indicator. And then think about the risk factors. We don't have a validated screening tool, but we know these are high risk factors. So if you're getting a social history, and you ask about, well, where do you live? I'm on the streets. You find out, have you ever run away? Yes. How many times have you run away in the last year? Oh, about 3. You might ask more questions about how long do you stay out each time? Do you stay overnight or a week? Oh, a couple weeks. Well, where do you stay? How do you get along when you're gone? Oh, I stay with friends. Well, who are these friends? And are they your same age? Those kinds of things can lead you to get a lot of information that says, oh my goodness, this child is running away. What's she running away from? So you ask about her home life, and you find out there's a lot of intimate partner violence, or there's a lot of drug use at home, or she's been sexually abused. Very high percentage of kids who are trafficked have a history of sexual abuse, anywhere from 60 to 90%, depending on the person you ask. If they're involved in a gang, you see a gang tattoo. Think about that as a possibility, because that's becoming much, much more common now for gangs to be involved in human trafficking. If you have, especially a boy, and their LGBTQ status, think about that. There's a relatively high percentage of boys who are human trafficking victims are in the LGBTQ category. And then poverty as well. So if you're asking about these things and you find there's a truancy problem, you find there's a runaway problem, you find the child is using a lot of drugs, think about this as a possibility. You can also think about the adverse health effects of trafficking and say, well, okay, so if a child is really depressed, their suicide attempts are up greater than the normal adolescent. So if a child comes in with a suicide attempt, maybe that's somebody I should screen. If a child comes in with beaten up and has kind of a questionable history about that, maybe I should screen for that. If the child comes in who's 15 and has the second bout of gonorrhea, that's a risk factor. Ask about that. So we can find out whether they've had these in the past and use that as our potential indicators that we need to ask more questions. Tattoos is an interesting one, where many girls who belong to traffickers are forced to get tattoos that have the trafficker's name on it or are sexually explicit. So we had one girl who had cash only written across her lower back, and there are other ones where they have like a barcode. And sometimes these tattoos are in kind of hidden places, but essentially they're branding. It's the trafficker saying, you are mine. And so if you see somebody with a name of a man as a tattoo, ask some more questions about that. When did you get the tattoo? What does it mean? You know, whose idea was it to get the tattoo? Who was with you when you got the tattoo? Because that may be an indicator as well. Now, I'm not saying every child who has a flower tattoo is necessarily a human trafficking victim. Probably a lot of you have tattoos. But so it's not a given whatsoever, but it's something to think about and something to document. If you see a child who is sort of dressed, normally, but has one very expensive item, or 2 cell phones, or hotel keys in her pocket, think about the possibility that something else is going on. Because many times, at least in the initial stage, during the boyfriend courting stage, he'll buy her things, and he might get her a really expensive watch, a really expensive cell phone. So if you have something that's sort of out of place with the rest of the way she's dressed, think about that as well. Well, the medical history, I think, is critically important, because as medical providers, we're going to get information that other people are not going to get. And so we have to make sure we ask these questions. And the whole point of the medical history is not to do a forensic interview. It's not that at all. It's essentially an expanded medical history that we do with all patients. We want to assess their safety and their health and their needs. If we're not sure whether they're being trafficked or not, this is the time when we ask the screening questions. When you're asking about STIs and you're asking about the social situation, so that you get those indicators going off in your head and saying, oh, I better ask more questions. So the medical history is targeting assessing the safety and health needs of the child. It may be really variable in length. Sometimes kids will come in, they are not willing to talk to us. This is the last person they want to talk to. We're just another badass authoritarian figure, and they're not going to talk to us at all. So it may be a 3-minute interview and you don't get any information. Or they may be in so much pain that they're not going to be able to talk to us. On the other hand, it's not unusual for them to be very willing to talk and spend 45 minutes giving us very valuable information. So it can really vary in length, and if you get the sense that you're not going to have much time, in your mind, think about, I got to hit the highlights. What are the priorities here? What do I need to ask before she refuses to answer any questions? I like to point out that the medical interview is also a good opportunity for anticipatory guidance. You think about it, a lot of very street-savvy kids have no idea why they're using condoms, what an STI really is and how you get it, even sometimes how to use a condom. So being able to explain and answer questions about gonorrhea and chlamydia, things like that can be very, very helpful and ultimately prevent complications down the line. So think about that while you're talking to the child. And many times, as I sort of alluded to, the child may be unwilling to talk to us. Again, if she has been just hauled in by law enforcement because they picked her up on a runaway warrant, and they realize that she's probably a trafficking victim, or they do a raid and they see her in a known prostitution spot. So they bring her in for a medical exam. We may be the last people she wants to talk to. So she may be very hostile and uncooperative. She may be very manipulative because that's what she's had, or he or she has had to do to survive on the streets. So a boy who's been living 6 months out on the streets is going to be manipulative because that's what he has to do to survive. And they may not want to talk to us. They may be afraid of opening up and saying anything. If the trafficker is sitting right there, they're going to be afraid to say anything because they've been told not to give any information. I think that one of the things that makes working with victims very challenging sometimes is that, for the most part, and I'm assuming on your part, I don't know, at least on my part, I have not had those experiences in my life. They're very, very different and outside the realm of anything I've had happen to me. And so it requires a very conscious effort to be very non-judgmental, very open, just listening and trying to get information and not passing judgment, not saying, well, I wouldn't have done that, that was a stupid decision, not even in your mind, because we can't know what the child has had to do to survive. Again, she may have been told to lie, or the boy may be so intoxicated he can't talk to us. So we may not get a whole lot of information. One thing that's really critical as healthcare providers, though, is to take a trauma-informed approach. So we have to assume that if the child is a trafficking victim, they've had incredible stress, all that physical and sexual violence, all that psychological abuse. So they are very likely very traumatized, and we want to make sure that we monitor while we're talking to them to make sure that we minimize the possibility of re-traumatizing them by our questions. And so we have to assume, okay, this may be very difficult for her to talk about, or him to talk about being beaten up by a buyer and left on the side of the road. He may not want to talk about that, and if he does, he may get very traumatized by that. So we have to be really aware of that and try to minimize that. One of the primary concerns, if you think you are dealing with a trafficking victim, is to do your best to help ensure the safety of the child. Let's say you suspect the guy who's with her to be her trafficker. Well, you don't want to start asking her a lot of questions about trafficking with him sitting right there, because he's going to beat the tarnation out of her. So we need to separate them, just like for any adolescent. You separate them, get him out of the room if you can. Now, you can't pick him up with a shirt collar and throw him out, but you can say this. You can say, it's our policy to talk to all adolescents alone. They're old enough to be interviewed alone, and so that's what we do with all adolescents. And so I'll need to ask you to step out. There's a waiting room down the hall. If he says, I don't want to step out, you say, well, I really would like to, and you can try to push it, you can't force it. And if she doesn't want him to go, then you can't force it. But if you can, get him out of the room so that you can talk to the child alone. If there's no way, he's not going to leave the child, another alternative may be to pretend that you need to do a chest x-ray or something, get the child out of the room and into the radiology department where you can be with her alone or him alone and talk to them more clearly. But when you sit down, let's say the guy decides to leave. He's pissed, but he's going to leave anyway. So he goes out. It's important to make sure that he's not lurking right outside the door and that people aren't coming in and out, nursing staff coming in and out of the door, allowing him to potentially hear what we're talking about. So just make sure you keep that in your mind. And then start off by saying, listen, do you feel safe talking to me? And are you able to tell me if you start not feeling safe talking to me? How can I make you feel safe? Because you want to constantly assess that she knows better than we can whether she's safe or not and what may happen. It may be safe for her to talk to us for 5 minutes, but we can't talk for 45 minutes because then the trafficker's going to wonder, what is she telling him about? And then assume the worst. So we need to be very cognizant of that. As I mentioned before, while we do this with every patient, it's absolutely critical to treat the child with respect and make sure that you're a very non-judgmental, open attitude. And so not the frowning, not the saying, oh, what made you decide to do that? Well, that was pretty stupid. No, we're not going to say that. But, there are people who might. So we want to encourage those around us as well not to be judgmental, that we have to just sort of be very open and accept her as she is. We can't go in and say, oh, I'm going to save you from this life, and you're never going to have to go back to that awful trafficker again, because she's going to look at you like you're nuts. That's her boyfriend. She's not being trafficked. She doesn't want you to save her. So we can't expect to change her attitude. It may be years before she can get herself far enough along that she can tell that she is actually a victim and is being exploited, and that then she's ready to leave. It may not be now. So we need to accept her where she is. If she calls him her boyfriend, you call him the boyfriend. It's important to explain the limits of confidentiality early on. And we do this with all adolescents, right? But this is extremely important. And I usually say something like, I'm not going to go out and make a point of calling your mom and telling her what we've talked about, but I can't guarantee that she won't have access to the charge, or some other guardian, or someone else, law enforcement or a social worker. So I'm going to ask you a lot of questions, and you can decide whether you want to answer them or not. It's her or his choice. We want to give them control. So he can decide just to not answer any questions if he wants to. Make sure that you say that. And then say, but if you tell me things, it will go in the report, and I can't guarantee that other people won't be able to see them. That way it's out there, and they know that they can't expect complete confidentiality. And I also preface it by, building rapport, as you always do, but also saying, I'm going to be asking you an awful lot of questions if you're willing to answer them. You don't have to answer any of them, but if you are willing to answer, there's more questions than most docs talk to you about. So it may seem kind of funny to you that I'm asking all these questions. But the reason why I'm asking them is because I want to be able to assess what I might be able to do for you, assess your health and what kind of health needs you might have, and what I might be able to do to help you. So there's a reason why I'm asking all these questions. Otherwise, you almost seem voyeuristic. So you want to make sure that they understand there's a reason for all that, and that they don't have to talk to me if they don't want to. These are just some tips for talking to the adolescent, and much of this is like forensic interviewing. Build the rapport and ask open-ended questions. Try to avoid the leading questions. Don't interrogate. Don't get into a power struggle. Those kinds of things. It's nothing new to you. But if people who have not had any experience with abused or traumatized kids, they may find these helpful. These are some of the street terms that are used. It really is kind of embarrassing if some people start rattling off terms and you have no idea what they're talking about. They're talking about the track, and you're thinking, what track? What? So it kind of helps if you know some of these terms. In-calls and call-ins and call-outs. Depends on a call-in is when the buyer goes to the child. A call-out means she goes to him. The renegade is a child who's working for herself, is not being under the control of a trafficker, for example. Just knowing some of these things is important. The seasoning is the process of breaking down the child and getting him or her ready to be turned out for sex work. And that's that period of indoctrination when they're establishing control, teaching the girl or the boy how to essentially be able to prostitute them. These are the major medical issues we want to cover. So if you think, okay, I've got 5 minutes of time, you want to cover some of these 4 areas. Besides, the chief complaint and worrying about why they're here now, the reproductive history can be very important. Asking about injuries and abuse in the past. Many of these kids have been abused before they ever ran away and got exploited. Asking about alcohol and drug use. The child may need to be referred to a drug rehab center or for a full assessment. And then, absolutely critical is doing a mental health screening. Lots of kids with very severe PTSD or major depression may be suicidal, and we need to be able to assess that. So, obviously, you're going to ask the questions about current physical complaints, the vaginal bleeding or the asthma attack or whatever, and the past medical history, yada, 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 allergies and medications. People are familiar with all that. But then go on to ask about the reproductive history. If they're willing to talk about it, it's very helpful to ask about current and prior symptoms of itching, discharge, bleeding, et cetera, et cetera. Any history of genital injury in the past. Have you ever been pregnant? Have you ever had an abortion? What about your periods? How long have you been sexually active? That might be your first clue. I've been sexually active since I was 11. That might be a clue that maybe we need to ask more questions of this child. She's at high risk. How many sexual partners have you had about? Don't forget to not assume sexuality. Ask, what gender person they prefer, and ask about birth control and condom use. I think we've talked about these. This can be extremely helpful. screening to figure out whether this is a high-risk child who may be a trafficking victim, or if you already know she's a victim or he's a victim, it can be very helpful for you to figure out what tests you need to do or referrals you may need to make, and what you need to look for in your exam. If you're to the point where you have a child who you don't know is being trafficked, but you have suspicions, let's say it's a runaway child and they've had a history of gonorrhea twice, you may want to ask more specific questions to screen specifically for trafficking. And these are possible questions to consider. Has anyone ever asked you to have sex in exchange for something? Money, food, drugs, shelter, clothing. This is a very common thing for kids who are living on the street. If they're runaway or homeless, they have to exchange sex to survive. So it's survival sex. And that can be a very enlightening question. You can also ask, has anyone ever asked you to have sex with somebody else? That's often one of the initial things that the boyfriend does as he's beginning to turn that relationship into one of pimp control, is to ask her to have sex with somebody else. Oh, honey, we're going to build a great life together, but we need money, so would you mind having sex with a couple guys? You do it anyway, now get some money for it, and we can have a great life. So he's asking her to have sex with somebody else. That's pretty unusual for a child who's not being trafficked to have a boyfriend or somebody ask her to have sex with somebody else. So that's a pretty pointed question. You can also ask about someone taking sexual pictures of you or posting them on the internet or threatening to post them on the internet. Now, there's a lot of sexting and posting pictures of yourself. It's not necessarily involved in sex trafficking, but that is a high-risk behavior. If the child is willing to talk to you, screening for prior sexual abuse is really important. And if they say, yes, actually I was sexually abused, the follow-up questions about, can you tell me, are you willing to tell me what happened and when it happened and who was the person and did it ever get investigated? Because this may be the first time she's ever told. That may be a whole other investigation that needs to be reported. And then asking about prior injuries and abuse. This can get at physical abuse in the home, which is maybe why the child ran away from home, is he was always getting beaten up by the drunk father. Or it may tell you that there's some dating violence or bullying going on over and above the violence within the exploitation setting. So asking things, ever been punched, kicked, choked, threatened, etc., by anyone? That can be very helpful. And if they say yes, then ask more follow-up questions. What was done about it? Who, what, when, where? Were you injured? Asking about whether they ever got medical attention is really important too, because if they did, it would be helpful to go look at those medical records. You may not want to necessarily ask, have you ever been choked, beaten, this litany of things have happened to you. You could take another approach and say, have you ever broken a bone? And tell me about the time you broke a bone. Have you ever lost consciousness? Well, tell me what happened then. Have you ever had someone hit you and then have your ribs hurt for a long time, like a rib fracture or something? So you can ask about specific injuries or signs or symptoms of trauma. Many kids who have been exploited have had closed head injuries, so they may have a memory loss, which could be a sign of brain injury, or more likely it's probably a sign of extreme stress and PTSD-related symptoms. So asking about memory, is your memory as good as it was a year ago, can be very helpful. If the child's willing to talk to us, I think it's important to sort of delve into the family situation. One of the things that you're going to do if you realize a child is being trafficked is you need to call the Division of Family and Children's Services. And the more information you have about the safety of the home, the better, because we don't want the child going home and then being beaten up or sexually abused, or have her run away 15 minutes after the defects worker drives away. So finding out about what's going on in the home, if the child is a runaway, what is he running from? And finding if they're a gang member or not. Now, they may not tell you the truth. Often they'll deny being a gang member, but there may be some. If you know the child's not living at home, let's say you're working at a public health clinic and a lot of runaway teens come in. And so it's pretty common for runaways to come in, and so you know this child's homeless. Ask them, where are you living and how do you get along? What do you do to survive? How do you get food? Where do you sleep? That kind of thing. Anyone ever asked you to do something you didn't want to do in exchange for something you need? And then I think this is very critical, and one of the top things that you need to do is to try to screen for mental health issues, not just a prior history of diagnosed diseases, but disorders rather, but also ask about current symptoms of depression or PTSD. So you might want to ask about intrusive thoughts. You ever get in your mind a thought that's really bothering you, you just can't get out of your mind? Do you have problems sleeping? Do you have problems waking up, you can't get back to sleep? Are you eating as well as you used to? Eating. Those kinds of things. Do you feel really sad sometimes? On a scale of 1 to 10, what's the worst you've ever felt? And what did you do when you felt that sad? And tell me about why you felt sad. Have you ever tried to hurt yourself? Have you ever tried to commit suicide? What did you do? Did anyone help you? Those kinds of things can be extremely, really important. And it's not all that unusual for us to need to get an immediate psychiatric referral in the emergency department because they are suicidal or very, very, very depressed. And then screening for substance use, again, very common among kids. And you may have your own way of screening with this, using like the HEADS screen or the CRAFT screen, or just using your own questions. But it's important to ask what kinds of drugs are used, and maybe not just say, do you ever use drugs? Because they're going to say no. But you might want to say, use alcohol, how often do you use alcohol? Do you use marijuana? Do you use cocaine? How often do you do that? Those kinds of things can be enlightening. And if someone says, well, yes, somebody gave me a pill 24 hours ago, and I don't remember what happened until about 3 hours ago, that would be very worrisome for a drug-facilitated sexual assault, and we'd want to get a drug screen on that. So being drugged by the buyers is not unusual. The exam then focuses on assessing acute conditions, obviously, but also looking for the chronic, untreated conditions. If kids have been trafficked for 6 months, a year, 2 years, they haven't probably had a whole lot of well-child checks, and they might have untreated conditions. We need to document all the injuries, acute injuries, remote injuries, and do that very carefully in a way that will help investigators. I think it's important to assess the overall health and status of the child, if they're dehydrated, if they're malnourished, if there are other long-term problems. And then usually we're asked to obtain a sexual assault kit, especially if there has been sexual activity within the last 72 hours. In some cases, you might even want to do it out to 96 hours, depending on the situation. But usually we get that. Again, you need to get the assent of the child for all of this, the exam, the history, the testing, the sexual assault kit. And if she says, I don't want a sexual assault kit, then we're not going to do it, even if law enforcement wants it. And then we need to test for sexually transmitted infections, and we typically assume the child will be lost to follow-up, and so we prophylactically treat just as we would an acute sexual assault. And then screen for alcohol and drugs. Again, obtaining assent is really critical, and explaining everything you're doing is very helpful too. Remember that it may be very traumatic for a child to have an anogenital exam. If she has been photographed and threatened to have photos of her naked having sex put on the internet, then if you have a camera or a camcorder for your genital exam, that may really freak him or her out. So we have to be very careful about that and cognizant of that. We had one child who became very, very distressed just by having to spread her legs and have the exam. And, you can kind of understand that. So we need to go very carefully and monitor constantly. If you have a child life specialist or someone there who can really help, a victim advocate, that's great. Absolutely need to have a chaperone. We don't want to get accused of anything, and want to make sure that somebody else can help us monitor the child. And explain the results of your exam. It's always very tempting to say, okay, all is done, and then you kind of rush out of the room. But you need to tell her, you look absolutely fine, or gee, you've got a laceration or cut here, but it's going to heal just fine. Explain what you found can be very helpful, and answer her questions. Good documentation is absolutely critical. How many people do exams on abused kids? Are there any SANE nurses or child abuse docs? Well, it's extremely important if you are doing an exam and you see injuries to document them visually. If you have a camera, that's the best, with a ruler in the picture. But also as a written description, just in case your camera doesn't work or something. You need to be able to describe it. There was a 2 by 3 centimeter reddish-brown bruise on the soft portion of the right cheek, for example. Because it's very important to be able to document this, and so that other people can know exactly how the child presented. And then take note of the tattoos and the inappropriate clothing. If the child has a very, very expensive watch and everything else looks pretty shabby, just make note of that. These are the areas where we often see inflicted trauma. Non-accidental trauma occurs in places where that's usually protected from accidental injuries. And we're always bumping our arm and our elbow and our knees. That's very common to have accidental injuries there, but you don't usually accidentally injure your torso or your neck, the soft part of the cheek, the inner thighs, the upper arms. And so if you see grab marks on the upper arm, that's pretty suggestive of inflicted trauma. And also, often there are restraint injuries, so look at the wrists and the ankles. We sort of covered this, the anogenital exam. Again, if the child assents to it, it's important to get a really good exam, look at the vulvar structures, and look for any evidence of trauma. Keeping in mind that in most cases, you're not going to see a lot of trauma. Even if the child was violently assaulted 10 days ago and had a lot of bruising, that may be completely cleared up and gone by the time we do our exam. And so there may not be anything to see, but we need to look anyway and test for infection. We do not necessarily do speculum exams on all our adolescent girls. We do if we suspect PID or if there's suspected internal trauma, but we don't automatically do it. So it's not absolutely necessary. This is just one of the 2 studies that's out there now that just emphasizes how fast genital injuries heal. They heal completely, rarely scar, and can be gone within a few days to a couple of weeks. And so extensive bruising can be gone after 3 weeks, and it's a completely normal exam. So again, the fact that you have a child with a nonspecific or normal exam now does not mean she did not have sex or that she did not have violent injuries in the past. This is the baseline testing. So we test for gonorrhea and chlamydia, trichomonas. We're following the CDC guidelines, the 2010 guidelines. We add hepatitis C, which is not part of the CDC guidelines, but we add that because these kids are so high risk. And so we throw that in as well. Keep in mind, though, that if you are testing at baseline and you get a positive gonorrhea result, that may reflect on her disease, that she has the infection, or it may reflect infected semen. For example, you stick your swab in and you get a glob of semen that's infected. So that you have to keep that in mind. And because so many kids will not come back for follow-up, we inevitably ask them to come back in 2 weeks. And 90% of the time, they're already run away again. And so we don't get them back. So we cannot test for gonorrhea and say, well, we'll wait for the test to come back, and then if it's positive, we'll treat them, because we don't see them again. So we assume they have gonorrhea, chlamydia, and trick, and treat as if they did. It's very high risk that they have these infections, so it's a good bet that they do. And the treatment is very benign. We may or may not start HIV prophylaxis. As you may know, HIV prophylaxis involves 2 drugs twice a day for 28 days. It makes you sick and nauseated. It's a horrible experience. And it does not guarantee that the child will not get HIV. But we discuss it and potentially offer it if we can be relatively sure that the child will be compliant, that there's somebody there to make her take the medication. If we know she's going to turn and run from her home, we're not going to start it, because the worst thing is to start HIV medication and then stop it midway. So there are certain conditions, if they're in the youth detention center, they're in a home where there's very close supervision, we might start HIV prophylaxis. It really sort of depends. Drug testing is not universally done. We do it if the child reports a memory lapse, like that example I just gave you. I don't remember what happened in the last 12 hours or so. Or if they come in with an altered mental status, or if there is some reason to think that perhaps they're going to go into withdrawal, we might, with their permission, get a drug screen. When we do drug screens, we do the urine drug screen. Do you guys do that in your emergency departments and the clinics? It's a very rapid turnaround, 9-drug screen. Very easy, very cheap, very fast, but it's not very sensitive. And so it's possible to have a negative urine drug screen with drugs on board. So keep that in mind. The child says, yeah, I took some pills yesterday. I took some, I don't know, took some pills yesterday, and it comes up negative. There may be something there, it's just not being picked up by the urine drug screen. So we also often will send a very sophisticated one out to Utah. It's called the Drug Facilitated Sexual Assault Screen. And it tests for over 100 drugs and picks up things like designer drugs and bath salts and things like that. But the problem with that is it's expensive. It's like $375, and it doesn't turn around for about a week, so you don't get the results for a while. Consider other possibilities. If you think the child's been beaten up, consider labs to screen for belly trauma. You may need a head CT, lab test to test for chronic conditions. There are other things that you might want to do. And then reporting. In Georgia, sex trafficking is a form of child abuse, and so we need to call DFACS. It's a crime. We need to call law enforcement. And probably the third call that's most important is a call to Georgia Cares. Has anyone heard of Georgia Cares? It's a state organization that serves as the entryway for children who are suspected victims of trafficking. And what they do is they keep track of all these kids and they provide services. They do an assessment, a really complete assessment, and they say, okay, this child needs schooling, she needs a place to stay, she needs therapy, she needs medical, and they make sure that she gets all that. And so they're kind of the umbrella organization that says, we can place her in this home and we'll make sure that she gets these services. So it's critical to call them from wherever you are. If you're in a clinic, you're in the emergency department, call them first, or right after a law enforcement and defects, because they'll help you take over. They'll say, okay, we'll do an assessment. That's it. It's great. If you are in an area where you need more information, the National Human Trafficking Resource Center hotline is available 24/7. What I like about this, if you happen to move away from Georgia and don't have something like Georgia Cares, is that you can call them any time, day or night, in any language, and ask them for resources. You know, I'm near Huntsville, Alabama, and I don't know what to do. So they'll say, well, in Huntsville, Alabama, there are these shelters or these residential centers, and you should call this police department. And they tell you what you can do. Very helpful. If you have a child who is from another country, and so he or she is an international victim, you should call the U.S. Immigration Custom Enforcement, or ICE. They are critically helpful in the crisis situation of coming in and saying, okay, this child needs an interpreter, they need immediate legal assistance, there are all sorts of immigration issues, and they can really be helpful. So keep that in mind. Immediate needs are, as much as food and clothing, as well as a place to stay. Possible medical referrals that we need to think about, obstetrics, gynecology, for example, health department, drug rehab. These are the kinds of things that we would need to say to law enforcement. Hey, you know what? This child needs drug rehab. Or tell Georgia Cares, the child is really screened high risk for a serious drug problem. They're going to need a drug assessment. And then they have long-term extended care, which again is where Georgia Cares comes in and can help you with that. So just to wind up, sex trafficking, major problem in the United States. We've talked a lot about risk factors, but keep in mind that a lot of kids don't have prominent risk factors. They may be recruited by being in a chat room. Your 14-year-old daughter who's up late at night playing around on Facebook or in chat rooms may be recruited by somebody, or somebody may try to recruit him or her. So they may not have a lot of risk factors, but many of them do. They virtually all will experience considerable complex trauma, psychological and physical and sexual trauma. And so we have a responsibility to try to assess that and provide as much care as we can. And when we can't provide the care, we need to make referrals. Keep in mind that in many cases, it becomes very depressing, but in many cases, when you do your exam, you spend 3 hours with this child and you really built a rapport, and you think they've told you a lot, and you work with Georgia Cares, and she's going to go to a treatment center for sexually trafficked kids. Great, you think this is really a win, this is great, this child's on her way, rebuild her life. You hear a week later, she's back out on the street, she's run away. And that is not uncommon, and I think that kids will make a number of passes through interventions before they are ready to leave. And for any number of reasons, it may not be right, just the right time. But I think it's important for us to know that if we can be non-judgmental, if we can gain their trust, if we can help them a little bit and give them resources, we may make them more likely to listen and open up next time. So it's not worthless, it's worth the effort. Thanks very much, I appreciate you listening.